Good morning and welcome to Comet Corner. This is a virtual series created by the UT Dallas Office of Research and in partnership with the schools across our campus to host chats with some of our notable alumni and hear how they have taken their research out into the world and made an impact. My name is Enrica Ziller, Research Education Programs and Outreach Manager in the Office of Research at the University of Texas at Dallas. As we move through today's session, I invite you to post questions into the chat for our guest speakers to discuss. Here to guide our conversation and introduce our distinguished alumnus is Dr. Tyler Miller. Dr. Miller is Chief of Medicine at the Dallas Veterans Affairs Hospital, Professor of Medicine at UT Southwestern Medical School, Vice Chair of Medicine at UT Southwestern, and a member of the Advisory Board of the Ackerman Center for Holocaust Studies at UT Dallas. As Chief of Medicine at the VA, Dr. Miller has worked to expand high-quality specialty medicine services to veterans in North Texas and recently managed the COVID pandemic in this group of patients. The Dallas VA is a major teaching hospital for UT Southwestern medical students, residents, and fellows. Dr. Miller also has basic research laboratory in the UT Southwestern main campus where he studies basic aspects of kidney disease. Dr. Miller, welcome.
First, thank you. Our speaker today is Sherwood Brown, M.D., Ph.D., and M.B.A. He is a professor with tenure, Vice Chair of Clinical Research, the Aradine S.R. Chair of Brain Science, Chief of the Division of Clinical Neuroscience, and Director of the Psychoneuroendocrine Research Program in the Department of Psychiatry at UT Southwestern Medical Center. He received his B.A. and Ph.D. degrees in chemistry from Texas Christian University, an M.D. from the University of Texas Medical School at Houston, and completed a psychiatry residency on the research track, followed by a research fellowship at UT Southwestern. In 2020, he obtained an M.B.A. with a healthcare organization leadership concentration from UT Dallas. He's board certified in both psychiatry and the subspecialty of consultation liaison psychiatry. For many years, he has conducted research on co-concurring conditions in people with mood disorders. He has over 200 publications and has been principal investigator on 18 grants from the National Institutes of Health and 20 grants from private foundations and the state of Texas in this and related areas. He is on the board of directors for the Academy of Consultation Liaison Psychiatry and chairs the research committee. He serves on several journal editorial boards, including the Journal of Affective Disorders, and is editor-in-chief of the Journal of Dual Diagnosis. In 2002, he was co-recipient of the Gerald R. Clairman Award for Clinical Research from the National Alliance for Research in Schizophrenia and Depression for a research project on the long-term effects of corticosteroid therapy on memory and the hippocampus. Dr. Brown will talk to us about the effects of stress on the human brain. Why is this a good topic for Veterans Day? There are many reasons. First, stress is a major characteristic of life in the military in peace and war in ways many of us can imagine and some of us know. Often the long-term consequences of learned behaviors caused by these stresses become part of veterans. Caring for them successfully requires our understanding not just their organic medical problems, but the effects of their military experiences on them as people. Dr. Brown's work is important in a broader context because it begins to understand the chemistry of the brain as it relates to behavior, in particular stress. This is an extremely complex and difficult area. The many cells and cell types in the brain communicate and change form using small molecules, many of which resemble drugs used to treat a wide range of conditions. Dr. Brown used behavioral effects of some of these drugs to begin to understand how small chemicals affect brain structure and aspects of behavior. He will tell us part of that story today.
Well, thank you very much for that nice introduction. I want to also thank UTD for inviting me here today. It's an honor. I want to begin, since this is Veterans Day, by acknowledging the great service our men and women in the armed forces and veterans of the armed forces provide for us and in keeping us safe in America, and the sacrifices they have given to our country. Well, today I'm going to tell a little about our research and how my research career developed, and finally I'm going to say a few words about how my experience at UT Dallas has shaped my research career. I'm a recent graduate. I received an M.B.A. from UTD earlier this year, so in that way it's had sort of a special influence on my career at a rather advanced stage within it. So my interest in this topic of what are the effects of stress, or particularly the stress hormone cortisol, on the human brain began when I was a resident, and I was interested in a project to pursue and the research track, and a very young new faculty member, an allergist at UT Southwestern, Dave Kahn, mentioned to a psychiatry faculty member who saw him for an allergy that he thought the psychiatric side effects of prescription corticosteroids were underappreciated, and she brought this information back to me. It interested me a lot, and I met with Dave and we discussed, and we've collaborated ever since that time on projects. And what I've tried to do over the years is to use this clinical observation to move backwards to the basic science research, and then come back to clinical practice by applying it to other groups of patients. And I'll try to walk everyone through that story in this presentation. So there is a history of medication side effects having an influence on psychiatry, and perhaps a classic example is the antihypertensive drug Reserpine, which is a very old drug, rarely used now, but it works by depleting types of neurotransmitters called monoamines, and that includes things like norepinephrine and serotonin. And back in the 1950s, they observed that when people received this blood pressure medicine, they often became depressed. And that observation actually led to the idea that, well, if depleting these neurotransmitters causes people to become depressed, maybe if we increase these neurotransmitters, we can treat depression. And that led to the development of the antidepressants used over the years, including the tricyclic antidepressants like Elavil or nortriptyline that work primarily on norepinephrine, and the newer antidepressants such as Prozac that work on serotonin. A little bit more recently, there were similar observations with a drug called Interferon alfa, which is used for hepatitis C and also some in cancer treatment. And this drug has very pro-inflammatory effects. It works on cytokines and really increases inflammation. And there was an observation that people tend to become depressed when they receive this drug, and that's led to great interest that's continued for over 20 years in neuroinflammation and the potential effects of cytokines and inflammation on depression. So our hope was with these medications, corticosteroids, to pursue a similar path. And well, what are these drugs? Well, I'll first mention that they are steroids, and that's defined by having this 4-ring nucleus, which is called the steroid nucleus. And the particular steroid I'm showing the chemical structure of here is cortisol, which is our stress hormone. But there are many examples. There's prednisone, which is probably the most widely prescribed corticosteroid, and it's actually what's called a prodrug. The actual active metabolite is something called prednisolone, which is also sometimes used as a prescription drug, although usually people just receive prednisone. There's methylprednisone, which is solumedrol. Some people may have received that for things like poison ivy or other sort of conditions. Dexamethasone and hydrocortisone, which is a prescription drug, but it is actually cortisol, our stress hormone. And then in rodents, they have a slightly different stress hormone called corticosterone. And actually humans do have some corticosterone as well. It's present in about 10% the concentration of cortisol. And these corticosteroids are used for a variety of different common conditions. So they're used for their anti-inflammatory properties as well as their immunosuppressant properties. And they're used for things like allergies and asthma, which was sort of my entry into this field, but a variety of rheumatic disorders, transplant to prevent transplant rejection. They're used by dermatologists and for multiple sclerosis. And more recently, they've been in the news because one of these, dexamethasone, now is fairly widely used as part of treatment regimens for the coronavirus. And the idea that they had effects on the brain is not new. These medications first came out in about 1949, and by the early 50s, case reports of brain effects with corticosteroids or behavioral effects were already appearing in the literature. I'm a bit of a movie buff, so I'll give a movie analogy here. I did a calculation recently that my wife and I have probably attended about 1,400 movies in movie theaters since we met. So I've seen many movies, and there was actually a movie made about the psychiatric effects of corticosteroids back in 1956. It was called Bigger Than Life, and it's available on YouTube and I assume Netflix as well. But it was about a gentleman who actually, due to the sort of stimulating and energizing effects of the medication, began to abuse the medications. And it's over the years developed a bit of a cult following. It's sometimes interpreted as being commentary on life in the 1950s. So, what psychiatric conditions might this clinical observation about corticosteroids be relevant to? Well, what I began to focus on was mood disorders, and particularly bipolar disorder and depression. And these are illnesses that often are associated with elevated levels of cortisol. So people with mood disorders seem to have sort of an exaggerated stress response that leads to, on average, higher cortisol levels than in people without mood disorders. And it's also quite interesting that the mood symptoms with corticosteroids are very similar to those of bipolar disorder. People become manic, they become depressed, they can have a cycle between depression and mania. And the treatment response, what's known about it, is also seems to be similar to bipolar disorder, where the kind of mood stabilizer medications that work for bipolar disorder also seem to help alleviate some of these mood symptoms in people with corticosteroids. So my initial entry into this field was the idea that the psychiatric symptoms with corticosteroids were a model for bipolar disorder, in a way to sort of look at the potential effects of the cortisol elevation in people with mood disorders on their mood. And we published a number of papers, and I had a couple of externally funded grants as a resident on this topic. So we had success, and I still publish some on this topic, but there were also some challenges. And the main one is that to really see a big change in mood, like the gentleman in the movie Bigger Than Life, it really takes one of two things. You either have to study people on very high doses of corticosteroids, and over the years, the doses have tended to go down. What they gave in the 1950s, they wouldn't normally give to people nowadays. And otherwise, the mood symptoms are really uncommon. So if you study people on lower doses, you would need to be able to study a whole lot of people to find people who had really clinically significant mood changes with them. So with that in mind, we began to develop a different model for what we would do with the clinical observation about corticosteroids. And we began to focus on a brain region called the hippocampus, which is this, it's in blue on this picture. And the hippocampus, although it's not a very large brain region, it does have what's called subfields, or smaller regions identified within it. And I just do want to point out this region, the dentate gyrus and CA3 region of the hippocampus, because I'm going to come back to that several times during the talk. But the CA3 region seems to be particularly important in neurodegenerative diseases such as Alzheimer's disease, and that's a region we've focused on quite a bit in our research. So what the hippocampus does is it helps us make memories. And to give a very extreme example of what not having a hippocampus can do, I'm going to mention the case of HM, which anyone who has taken a neuroscience course knows about HM, and his real name was Henry Meliasen, and his identity was revealed after his passing some years ago. But what happened was, when he was a child, he had a brain injury. I believe it was a bicycle accident, and after that time he developed seizures. And the hippocampus is often a focus of seizure activity. So neurosurgeons, to control his very severe seizures that couldn't be controlled with medications, removed parts of his temporal lobe, including most of his hippocampus on both sides. And after that time, he was not able to form new memories. So he was used a lot to help us learn about the hippocampus, and unfortunately his very tragic story was very helpful to science. Since I am a movie buff, I will mention that there was a really wonderful movie made about 20 years ago that sort of fictionalized the story of HM and added it to a story somewhat like the movie or TV show The Fugitive. And in this movie, the man was injured and received a head injury by a person who killed his wife, and after that time he was not able to form new memories, but he nonetheless looks for the killer of his wife throughout the movie. And that's actually it's a terrific movie. It's the one that made director Christopher Nolan famous. So on an extreme level, that's sort of what the hippocampus does. But on a more practical level, if someone's hippocampus wasn't working quite as well, they would show much milder signs of inability to form memories. And this is very relevant to animal models of stress or corticosteroid administration. And one model they often use, and it's shown on the left here, is what's called restraint stress. So they'll restrain rats, and that's very stressful to them. It causes corticosterone, their rat corticosteroid, to go up, and then researchers have looked at their hippocampus after this stress, or they've sometimes just administered corticosterone to them. And what they found is this, that sort of a early short time, almost always reversible likely effect, is that the neuron has these projections coming off of it that are called apical dendrites, and they help the neuron communicate with other neurons. And in a stressed condition, which is shown on the right side here, these apical dendrites tend to get shorter or retract or atrophy. And then a longer term effect of stress is shown in the bottom right corner here, where this CA3 region of the hippocampus, which seems to be particularly vulnerable to stress, in the unstressed condition has lots of neurons, and in the stress condition, I don't think this picture shows it terribly well, but there are fewer neurons present in the stress condition, and this sort of loss of neurons may be more difficult to reverse than the changes within the dendrites. So this is potentially very important to humans, and there wasn't much known about the effects of corticosteroids on the human hippocampus when we entered the field, but there was something known about their effects on memory. People had looked at that, and what they found was that rather mild memory changes with corticosteroid administration were very common, and they occur really quickly. Even one dose can lead to a memory change, and they occur at fairly modest doses. So unlike mood symptoms that require big doses and some time to develop, the memory change, which is, we think, related to a change within the hippocampus, was quite common and quite easy to study. So with that in mind, we begin to use corticosteroid excess or corticosteroid administration to determine whether corticosteroid excess causes changes in the human hippocampus. So we were interested in translating these preclinical findings into humans using people receiving these medications as a model system to study this. And it's important to several human populations that are rather large. One is people taking prescription corticosteroids, and although the data are kind of thin, it appears that potentially 1% of the population is taking corticosteroids at any one time. At least that's what they found in the United Kingdom. And in older people, senior citizens, they found that about 3% were taking corticosteroids at any one time. And moving back to mood disorders, this observation is also potentially useful or important for mood disorders because people, as we said earlier, people with depression and also bipolar disorder tend to have elevated cortisol levels or an exaggerated stress response. And also there was some evidence that people with mood disorders tend to have poor memory. And at the time we entered the field, the data were just beginning to emerge that they also had, on average, smaller hippocampal size than people without depression. So what we were interested in looking at is, well, could these findings be related? Might the cortisol elevation in some way potentially be the cause of the mood or the smaller hippocampal size and the poor memory of people with mood disorders? So this population of people taking prescription corticosteroids is really good to study this kind of question for a couple of reasons. One, as I mentioned earlier, a lot of people get these medications, potentially 1% of the population. They're given for a variety of common conditions. And also, it's very easy with this population to calculate the dose of the corticosteroid and the duration of exposure to the corticosteroid. And also, it offers opportunity, at least sometimes, to study the brain before, during, and even after the time someone's exposed to the corticosteroids. So with that in mind, we began to study the brains of people receiving corticosteroids, again with an eye on learning more about what the effects of stress or cortisol elevations might be on the human brain. So what we've done is we enrolled a group of people taking prescription corticosteroids. In this case, it was prednisone, for an average time of about 8 years, and a group of controls that had similar medical histories. A lot of these patients actually had asthma, but they had minimal corticosteroid use in their lifetime and none currently. And we did a neuroimaging study and looked at their cognition during the time they were on the corticosteroids. And what we found was that they did have significantly poorer memory than the group not on the corticosteroids. So it does suggest there's a sort of a clinical effect related to the hippocampus that could be observed. And we also found that their hippocampus was on average about 9% smaller than the other patient group. So this is quite important. The hippocampus, it decreases normally in size, which is concerning if you think about this too much, by about 0.8% per year in an adult. So if you have a 9% smaller hippocampus, that means you have about 11 years of additional hippocampal aging that's taken place. We've also, as neuroimaging techniques have begun to improve, we've tried to take this sort of translation of animal models that corticosteroids do have effects on the hippocampus one step further to look at the actual regions of the hippocampus that are most affected. And fairly recently, we did a study in a group of people who had taken corticosteroids, and this time for an average duration of about 6 years. And we looked at the relationship between their hippocampal size and the cumulative dose of corticosteroids that they had received. And what we found was, in looking at several regions of the hippocampus and around the hippocampus, was that one region stood out, and it's that same region that's affected most strongly in animal models. This is that dentate gyrus CA3 region, was the one that was significantly associated with the cumulative dose of corticosteroids. We also found that the relationship was much stronger in people who are sort of middle-aged and older than it was in younger people. And this is also consistent with the animal literature, where it appears that the aging brain is more sensitive to the effects of corticosteroids. We've also tried to look at shorter-term effects of corticosteroids, try to understand, well, what might the sort of more acute or short-term effects of stress or cortisol elevations be on the human brain. And for this model, we often give healthy volunteers 3 days of cortisol or some other corticosteroid. And we really, at this the dose and duration that we give them the cortisol, we don't see generally any mood changes within this population, but we do see some interesting changes related to the hippocampus. We'll see, not surprisingly, an effect on memory. Their memory performance will go down. We're also using functional MRI, where they do actually a task to activate the hippocampus in the scanner. We see that the activation of the hippocampus seems to go down when they're receiving corticosteroids. And also, somewhat surprisingly, we found that actually even the size of their hippocampus went down by about 2%, with a somewhat greater change in women than in men. And this was, all these changes are, of course, completely reversible after 3 days. But it was interesting to think about that potentially 3 very stressful days, for example, might cause actually a temporary change in the structure of parts of our brain. And we also found that the size change that we saw in the hippocampus correlated with the blood levels of cortisol during the time they were receiving the cortisol administration. So this suggests again that even short-term corticosteroid exposure is associated with some changes within the hippocampus. We're also very interested in how we might block the effects of corticosteroids on the brain. So could we block the effects of stress on the hippocampus? And there are some very interesting clues from animal models. The idea has been that something called excitatory amino acids, which one example is glutamate, may be responsible for the changes in the hippocampus. And therefore, in animal models, they've looked at drugs that decrease the release of glutamate, and these are some of these are examples of these kinds of drugs are medications used for seizures. And they've also looked at what's called NMDA receptor antagonists, and an example is a commonly used drug for Alzheimer's disease. And when they pre-treat animals before the stress with these types of drugs, they don't see a change within the hippocampus, or they see a greatly decreased change. So we've tried to look at the same kinds of drugs in humans. So one drug they've looked at is an anti-seizure drug called phenytoin or Dilantin. And we found that if we gave people phenytoin at the same time we gave them cortisol for 3 days, that we didn't see the change in hippocampal size or even the memory change that we observed with cortisol alone. And we've also looked at reversibility. So we took people on long-term years of corticosteroid therapy, and we gave them another glutamate release inhibitor that's also used for seizures called lamotrigine or Lamictal. And we found that if we gave them this for a number of months, that their memory, which is again what the hippocampus does, was better if they received Lamictal than if they received placebo. And then we looked at this Alzheimer's drug memantine, or trade name is Namenda, which is, and we looked at it also in people who are receiving long-term corticosteroid therapy. And in one study, we found that their memory was better with memantine than with placebo. And in a more recent study, we actually looked at regions of the hippocampus. And going back to this dentate gyrus CA3 region that we're so interested in, we found that if they received memantine for a number of months, that actually the size of that sub-region of the hippocampus was larger than if they received placebo. So it looks like we were able to some extent, translate the sort of prevention or reversibility findings in animal models to human populations and give it some clinical relevance. So what are we looking at now? Well, we're very interested in how the depressed brain might react to cortisol. And there's some reason to think that people with depression, perhaps because they have high levels of cortisol sometimes over a long period of time, may not react as strongly to cortisol administration as people who are not depressed. And we're doing a study like that right now, where we're going to compare the brains of depressed and non-depressed people. We're also interested in looking at sex differences. I mentioned earlier we saw a difference where perhaps women showed a bigger change in hippocampal size with cortisol administration than men, and we're looking at that as well in the same study, actually. And we're also trying to sort of move the sort of mechanistic nature of our research and translational nature forward a bit, and we're hoping to use some neuroimaging methods that might help give us clues to whether perhaps it is the changes we see in the hippocampus might be related to dendritic shortening. You remember these are those projections from neurons that get decreased in animal models of stress. And I'll also just very, very briefly mention that our work in this area has also led to additional research in related areas that developed over the years. We began to study people with asthma, which was a largely unstudied area in terms of their brain. We found that their people with asthma are more likely to have mild cognitive impairment as they age than people without asthma. Other people have picked up on this and even shown that there may be an increased risk of dementia in some people with asthma. We found that there's really high prevalence of mood disorders in people with asthma, and we found that if you treat the mood disorder, their asthma gets a lot better as well. So we've had numerous studies over the years in people with asthma. We also never gave up on our interest in bipolar disorder, and we've done a number of studies looking at substance abuse and the treatment of people with substance use and bipolar disorder, because the highest rates of substance abuse of really any psychiatric illness are observed in people with bipolar disorder. And we're also interested in a type of hormones called neurotransmitter, or rather neurosteroids, that are, so they structurally look a bit like corticosteroids, but they have very different properties. And some of these are made in the brain, and some of them are actually sold as over-the-counter supplements, and one has actually even received FDA approval for treatment of postpartum depression. But we think these sort of neurosteroids may have great potential for the treatment of mood disorders. And so in closing, I'll say a few words about how my experience as a student at UTD has influenced my work. And I frequently say very good things about what a really extraordinarily positive experience it was being in an M.B.A. program at UT Dallas. And one of the best things that I worked with lots of great people, including my classmates in the program, but also the faculty and staff at UTD. I just can't say enough positive things about them. And it gave me an exposure to a different way of thinking. So it was a way to sort of move out of the way of thinking of academic medicine and begin to see how people in other fields might think about problems and how to address them. And one of the ways that I feel like they think about differently is in some ways the workplace. So there's a great emphasis within the business world on work engagement, the climate, the culture, the values of the workplace. And I'll even mention, because one of our classes emphasized this point, the idea of totems and taboos. So these would be things that you are expected to do and expected not to do. And I certainly never heard that term in the context of the workplace, but I found that a bit amusing, because the term is so associated with Carl Jung, who is a psychiatrist and psychoanalyst, but psychiatrists definitely don't think much about that in the context of the workplace. I also was able to learn a lot about something called coaching as a leadership style, which is very similar to a type of psychotherapy called motivational interviewing. If I were going to just in a few words describe it, I would say it's different from mentoring in that you're not giving advice so much as you're taking the time to sort of explore a problem with someone and help them find the answers to it. And another area where I felt like the business world was perhaps ahead of us in academic medicine was this idea of measuring success. So if you're going to do something, how are you going to know if the change was successful? What are your outcome measures going to be? And I found that interesting as well. As scientists, we always think about what success in an experiment will look like and what our outcome measures are. But in areas like making changes within an office or a workplace, or one does not often think about, well, if we make this change, if we go to the effort to change it, if we spend potentially money to change it, how will we know if that was successful or not? I felt like the program gave me a perspective on that I didn't have before. Also, something I hadn't really thought about, but a biostatistician in our group mentioned to me recently that they thought I'm much more interested in quality improvement projects now than I was before I took the M.B.A. courses, and I think that's probably true. And finally, I guess what interests me always is if I'm going to do a project or learn about something, it's sharing it with the world, publishing it in scientific journals. And I was able to do several very interesting, I think, projects during my time in the M.B.A. program. And it's been very rewarding to sort of take those projects, develop them a bit further, and publish them in journals and really expand the sorts of research that I do. One had to do with healthcare economics. It's already been published. Another one had to do with issues like institutional pride and work engagement that was published in a healthcare management journal. And the capstone project for my M.B.A. program is currently under review by a peer-reviewed journal now. So those are some of the ways I think the program has changed my outlook on my work. And finally, I do want to acknowledge my terrific research group that we have that are invaluable, and I certainly couldn't do things without their tremendous help. And I'll mention that several of them, such as David Martinez and Maisha Rizaki, our newest member, are Comets and UTD graduates, and another one, Moses Samaran, will soon be a student at UTD. And then finally, you can't do anything in research without some research support. So I want to acknowledge and thank our funding sources for our current research studies. And with that, I'll close, and I want to thank you for listening to my presentation.
Well, that was a wonderful adventure through modern psychiatry. And one thought I had is that post-traumatic stress disorder, or PTSD, is a common problem in the VA, and it's also common in the civilian population. It's a condition that's very difficult to treat, and I think largely people have relied on cognitive therapy. But looking at your work, you could also think of it as a very deeply learned response to a trauma with triggers that will almost inspire automatic behaviors that certainly represents changes in the structure and biochemistry of the brain, which would explain why it's very difficult to treat. You essentially have to unlearn and undo structure and chemistry. So these ideas, I think, have really important implications for behavioral therapy and for psychiatry. What do you think?
Well, yeah, PTSD, I agree. It's a very interesting topic, and could almost give a presentation on the sort of cortisol and PTSD and this relevance as a separate talk. I will mention a few words about that, but you're right. In combat veterans, PTSD is quite common. Most studies show 10 to 20%. Some show higher prevalence of PTSD in combat veterans. And the sort of neuroendocrine system or cortisol story with PTSD is different than with depression, and a bit counterintuitive in a way. There are studies suggesting that the size of the hippocampus is smaller in people with PTSD, but it's not at all clear whether it's due to cortisol levels. And in fact, the preponderance of the evidence suggests that people with PTSD actually have slightly lower cortisol levels than people without PTSD. So they really don't have a high cortisol levels. And there was an interesting study done some years ago where they looked at combat veterans who had PTSD and who did not, and the veterans they looked at had identical twins, and they looked at the size of the hippocampus and the people with PTSD and their identical twin, and they found that the identical twin who didn't have combat exposure had a smaller hippocampal size than the twin of the person with the veteran without PTSD. So it was interesting. It suggested potentially that the hippocampus and potentially the way memories might be processed might be, rather than a consequence of PTSD, might be a risk factor for the development of PTSD. So also I'll just mention again this story about cortisol and PTSD has led to some interesting findings, and they're sort of relevant to psychotherapy and some of the sort of more psychotherapy or behavioral type therapies that are used with PTSD have sometimes been combined with brief exposure or administration of corticosteroids, and there's some evidence that that may be helpful in sort of extinguishing some of those memories or some of the symptoms of PTSD. And there's also some very interesting data, not from veterans, but I think potentially relevant to veterans. It's from a hospital population, and it turns out a fair number of people from an intensive care unit experience will develop PTSD-like symptoms. And their corticosteroids are sometimes used in people with what's called sepsis, which is sort of the body's reaction to bacteria in the bloodstream. And what they've found is that if people received corticosteroids for this, that during their time in the ICU, that they were less likely to develop these PTSD-like symptoms than the people who didn't receive them. So there may even be potentially some role for corticosteroids in preventing the development of PTSD.
It's almost as if the memories are too good in PTSD.
Yes.
Another area that I think might be interesting for the group is that in addition to your M.B.A, I think you mentioned to me that you have a lot of contacts and collaborators at UTD. How did you get involved with UTD on that level?
Okay. Well, there are many collaborations between UTD and UT Southwestern, and I wish there were even more, but I've had many collaborations with people at the Center for Vital Longevity, including doctors Denise Park and Goggin Wig, and also at the Center for Brain Health. I've collaborated a lot with Dr. Francesca Philby, and then also at the main campus of the school, I've collaborated with Dr. Krista McIntyre. And those have all been very meaningful collaborations, often related to the use of neuroimaging or with Dr. McIntyre, her perspective on the sort of basic science of some of these stress questions that we're interested in.
I think the audience may have some questions at this point.
Thank you, Dr. Miller and Dr. Brown. We do have a few questions in the queue for you both. The first one, does the cortisol increase stress, or is it stress that increases cortisol?
That's a very good question, and really the first response, the fastest response, is this sort of what would be considered sort of the adrenaline response of stress, sort of the fight or flight mechanism, and that occurs very, very rapidly, and that seems to be what leads to the cortisol response.
Excellent. And is cortisol also increased with obese people, or perhaps with obesity? Is there an increased risk for that?
Well, yeah, I don't know the answer about the like body mass index in relation to cortisol. There there is, I will say this, that there is some evidence that, for example, elevated cortisol will, over a period of time, will lead to some things like there's sort of, for example, the deposit of adipose tissue around sort of the midsection, or an increased waist-hip ratio. So I suppose that would be consistent with either some cortisol increase or some change in one's sensitivity to cortisol.
Okay. And then how can you see the size of the hippocampus?
Well, what you do is you do an MRI scan, and it provides a very nice sort of picture of the hippocampus. And the technology is really improved over the years, where now there's just very stunning pictures of the hippocampus. And then what is done, it's then measured using a variety of methods. And the old-fashioned method is to essentially measure it by hand. And what you do is you go through slices of the hippocampus. So you look at images and you measure that, so essentially sort of like an Etch-a-Sketch set. You measure the sort of area of the hippocampus throughout the hippocampus, and then those areas are summed up to provide a volume. And more modern methods actually do that using automated programs. With one of them that's widely used is something called FreeSurfer, and it does the job for us. Now, in animal models, they typically actually measure the actual hippocampus. At the end of a stress model, the animals are often sacrificed and the size measured directly.
Okay, thank you. And where does cortisol come from? Where is it created in the body?
Oh, okay. So it's made in the adrenal glands, which are sort of set over your kidneys. So the sort of stress response that leads to cortisol begins with something called CRH, or corticotropin releasing hormone, or corticotropin releasing factor, and then that leads to that comes from the hypothalamus, and that leads to a part of the brain, the pituitary, to increase something called ACTH, and then that goes into the blood and it acts on the adrenal glands and increases our cortisol levels. And normally there's sort of a loop there where then if the cortisol goes up, it regulates itself by acting on those parts of the brain to sort of decrease its release back to normal levels.
Excellent. I believe, oh, we just got another one in too. So 2 more questions. And I believe you just kind of referenced an answer to this next one, but I'll go through and read it. Is cortisol a type of hormone like estrogen? If so, do you think that is the reason we see more corticosteroids in females? Does hormone replacement therapy increase the levels of cortisol?
Oh, those are really good questions, and yes, it is. Well, I guess I'll say this: there are hormones, as is testosterone and progesterone, and they do look chemically fairly similar. They all have that 4-ring structure I mentioned of a steroid nucleus, but they act on different receptors. And there is some research into the sort of interactions between the other hormones like estrogen and cortisol, but estrogen itself doesn't necessarily mean your cortisol levels are going to be higher. We don't really know yet what the exact mechanisms by which perhaps the hippocampus in women might be a little bit more sensitive to the effects of cortisol than men, although similar findings have been observed in animal models. But interestingly, the effects of long-term stress in animal models seem to suggest that the female animal models are actually more resilient to stress than the male animals. We don't know whether that's true. Any of this is true in humans yet, though.
Okay, great. And I think we just have one more question. Can you elaborate more on those who have PTSD having lower cortisol levels?
Well, it's a very fascinating finding, and I'll say a little bit more about it. When I say they're lower too, they're probably not what an endocrinologist would call as lower. They're within normal range. It's just if you look at their levels, and this has been done many times, that their levels are on average lower than people without PTSD. And what's also interesting is there's ways to measure sort of the sensitivity one might have to corticosteroids as well. You can measure in the blood at least the concentration and the sensitivity of the glucocorticoid receptor. And what they found is kind of opposite findings in depression, where it looks like that the receptor, maybe due to the high cortisol levels, is kind of there are fewer receptors and they're maybe less sensitive. But in PTSD, there seem to be more receptors and perhaps more sensitive to the effects. So it could be that people with PTSD have sort of perhaps due to the glucocorticoid receptor or other things, might have a enhanced sensitivity to the stress hormone cortisol.
Asking Dr. Miller if you had anything to add to that.
Oh, I didn't hear that. No, I think Dr. Brown's talk and answers were elegant. Why would I want to get in his way?
Well, we do have, looks like one more question that I think we'll have time to fit in.
Okay.
And one comment that I will save until the end. Does diet, meditation, or certain vitamin regimens decrease the natural production of cortisol in an ordinary person under regular life stressors?
Okay, that's a good question. I'm not aware of vitamins making much difference, but yes, certainly the things that sort of increase stress, increase anxiety, and have a calming effect could have the potential, at least temporarily, to sort of decrease the stress response and sort of lower cortisol levels for at least some period of time.
Excellent, excellent. And Dean Stephen Small wants to say that on behalf of the School of Behavioral and Brain Sciences, thanks for your talk and your extensive collaborations with BBS. So that was a very nice shout out.
It's my pleasure. Yeah.
And I do believe that's all the questions for today. Thank you both for sharing your time, talent, and resources with us, gentlemen. We really appreciate that. And thanks to everyone in the audience for attending this session today. In the meantime, we wish you all a safe and warm holiday season, as we won't see you until the new year. Thanks again for joining us today, and have a great afternoon, everyone.